I would like Dr. Aziz Sumru to introduce the groups. So we'll have idea who is joining us today.
Ehtisham Qazi from New York.
Okay, I think then our guest speaker is here. He is Dr. Phil Chan and he will introduce himself.
So good morning, everyone. My name is Phil Chan. It's a pleasure to be here. So I'm an infectious disease doctor here at Brown University. I work for the Rhode Island Department of Health and also serve as a consultant for the CDC on issues related to HIV and STDs. And let me first start off by saying that both myself and my colleagues were deeply saddened to hear what's going on in Pakistan. And please feel free to use us here at Brown University and elsewhere to do whatever we can to help the situation. I know that you've all engaged some stakeholders across the world and there's a lot of help coming in. But certainly feel free now and in the future to use us, certainly at the very least, for any technical assistance or expertise that we can provide. Let me start off by saying the title of my talk today is talking about testing for HIV. I'm going to plan to talk for about 10 or 15 minutes and give a broad overview, and then I'm happy to take any questions as well. So let me start off by saying that HIV testing, in terms of addressing what's going on and outbreaks, that HIV testing is really the absolute cornerstone of addressing what's going on. And so that means making sure that you have correct testing algorithms set up, that you have sensitive and specific tests, and that you also have access to link people to care and get them in on treatment. So the major point too that I want to make now is that in this day and age, the treatments for HIV are phenomenal and fantastic, and people who are diagnosed and tested early and get on treatment have a normal life expectancy. So it sounds like there's a fair amount of panic and worry, and obviously this is a terrible situation. But on the flip side, HIV is really a manageable disease now, and for people that are diagnosed and get on treatment, their life expectancy is normal. And that's one thing I often tell people, certainly for people when they're first diagnosed, is that getting on treatment is key. And sometimes there's reluctance, of course, to test people, and there's sometimes stigma towards HIV, and people don't want to know their HIV status. But I think just reinforcing the message about HIV testing and the importance to get on medications is really a key point. The other thing to point out about the natural history of HIV is that once people are infected with HIV, they generally go for 6 to 8 years on average before they develop any symptoms. So HIV, as many of you I'm sure are aware, is a virus that affects the immune system. And so it's really sort of a brilliant strategy by HIV to infect the very system that's meant to kill it, to kill the virus. And so it generally takes about 6 to 8 years for HIV to degrade and attack the immune system. And after that time, people develop a suppressed immune system, termed to have AIDS, and that's when they get sick. When you have a suppressed immune system, that's when they get sick from all these other so-called opportunistic infections, right? Pneumonias, PCP, PJP pneumonia, meningitis, cryptococcal meningitis, etc. So the entire goal too of testing and treatment is to prevent progression to AIDS and obviously death, which usually accompanies it. The other thing from a public health standpoint to keep in mind, so testing and treatment obviously keeps people healthy, but the other huge thing to keep in mind is that when someone gets on treatment and becomes undetectable, that means that they're not going to transmit the virus to other people. And this has been really a cornerstone of addressing the HIV epidemic over the last 5 years. So there's a study that came out called HPTN 052 by Mike Cohen down at University of North Carolina. And this was a worldwide study that showed that if you're on treatment for HIV and you've become undetectable, then you're not going to transmit the HIV virus to others. So what that means is by testing and treating people is that you can effectively address the epidemic and HIV transmission in your community. And this has become a cornerstone and a pillar of addressing HIV outbreaks. just to clarify too, when we say undetectable, that means when you draw that tube of blood at the provider's office, it means that when you're on medicines, when you're not on medicines, you can generally have about 30 to 50,000 copies of HIV in that tube of blood, sometimes even higher, sometimes into the millions. When someone's effectively taking ARVs and on treatment over a couple months, the medications essentially make a person become undetectable. So HIV becomes undetectable in that tube of blood. It also means that there's minimal to no HIV in blood, in genital secretions, etc. So people aren't transmitting it. So that's really one of the key points too, and one reason why HIV testing and subsequent treatment is so important. I'm happy to take any questions too, if people want to enter that in the text box on the side. In terms of access to testing, what we've done in the United States and what people have done across the country as well, across the world as well, is really trying to make HIV testing as routine as possible. So what does that mean? It means that for any community clinics, it means for any doctor's office, and especially in terms of what's going on now, is that HIV testing should routinely be offered to everyone. And it sounds like a lot of the people who are testing positive don't have any really identifiable risk factors for HIV transmission. And I know the investigation into some of this is still going. So until it's really determined what's causing all this, it sounds like the best address is that HIV testing should just really be performed in all medical settings as possible. And that includes doctors, primary care doctors, community clinics, OB clinics. And what we've also done in the United States, and certainly in other settings across the world, is that there's a lot of NGOs and other organizations that have served as providing for safety net settings for people that have trouble accessing some of these clinic settings. So sort of just having a number of different approaches as you think about how to address this. In terms of HIV transmission, I do want to just make a couple points just to remind people. So HIV is really only transmitted through blood contaminated products or sex, and that includes genital secretion. So there is no risk of HIV transmission through kissing, through deep kissing, through handshakes, through toilet seats, etc. It's only having, I'm going to use some very direct language here, penile vaginal sex, anal sex, injection drug use, blood transfusions, etc. There's little to no risk through oral sex, as well as I mentioned kissing as well. In general, across the world, we do think about populations that are at higher risk for HIV, people that use injection drugs, contaminated blood supplies or medical equipment can certainly do it, and then sex, both between heterosexuals as well as gay and bisexual couples. So I just want to remind people about some of the transmission factors for HIV, but also to reinforce, and certainly in a community that has not dealt with HIV before, that you can't get it, if a family member has HIV, you can't get it from routine contact in the house. You can't get it through cooking. You can't get it through sharing a toothbrush even, or showering, or using the same soap. So all that should be safe. It's only through real, intimate, or other blood contact that you can transmit HIV. As I mentioned in terms of natural history, and this is a key point in terms of testing and especially what's going on, the natural history, as I mentioned, of HIV, unfortunately, is that it can enter a latent state over 6 to 8 years. So you can have no symptoms for many years, during which time that you can transmit HIV, and people's immune systems are getting sicker and sicker. So it's really important to test early as much as you can. The other thing that I want to make a point about is that early on, when people first get infected by HIV, a lot of times they have a febrile illness known as Retroviral Syndrome. And so this can be a very nasty flu-like symptom. Unfortunately, a lot of people, develop colds or flus throughout the year. So it can be very, very, very difficult to tell when someone's first infected with HIV versus what may be, the flu or a cold. In terms of the testing for HIV, I'm unsure what testing modalities are available. in Pakistan at the moment. I will say though that the cornerstone of testing for HIV involves antibody tests. There's a number, and I'm guessing that these are also available in country. There's a lot of rapid tests that are available across the world. And these rapid tests include swabs of the mouth or potentially testing through a finger stick blood test. Rapid tests that are approved by the WHO, the World Health Organization, as well as the ones that are used in the United States, are incredibly effective in testing for HIV. The ones we've had tremendous advances in HIV testing. As long as the test is recommended by the WHO or here in the United States, it's going to be a good test. And if there's any questions about that, please do feel free to reach out to us. But the tests in general that are available are fantastic. So it's recommended by the WHO, and the same tests that we use here in the United States are antibody-based tests. There are a number of generations of tests. There's a question here that talks about antigen testing as well. The latest tests available for HIV include an antibody and an antigen-based test. And these are so-called fourth-generation HIV tests. In general, these fourth-generation blood tests tend to be blood tests that are done in a hospital or specialty lab setting. There are some rapid fourth-generation tests, but to tell you the truth, these are not known to be any better than the third-generation rapid tests. It's the fourth-generation hospital-based tests that are really the best. However, it is totally reasonable and totally legitimate, and we even use them in our community settings here in our state in the United States to use rapid-based testing, just antibody testing to diagnose HIV. So the point is that you don't need to use an antigen test to diagnose HIV. The benefit of using the fourth-generation antigen-based test are that it does close the window of HIV testing. And so this is the one key point about HIV testing, just to really highlight, is that the antibody test, since the tests detect antibodies, you have to have formed antibodies. And so it generally takes on average of about 4 weeks, 3 to 4 weeks after someone is infected before the antibody test to be positive. So that means that occasionally in someone that has HIV, the test will be negative. And the most likely reason is because that they're in the first window period, during the first 3 to 4 weeks of being infected with HIV. The answer to that is to either test people again, so to test people again in 2 to 3 months, or you could do a viral load testing to look and diagnose an acute phase of HIV. However, if viral load testing is not available, it is totally reasonable to repeat an HIV test in 2 to 3 months. So I would say for the situation that's going on, and it sounds like due to limited resources, is that I would probably recommend routine HIV testing with antibody tests. Rapid tests again are totally good and fantastic. And then if there's any question about exposure, is to test someone again. If there's any question that someone may be in an acute phase or recently exposed, is to test them again in 2 to 3 months with the same test, which is okay. I will also keep in mind that here in the United States and elsewhere, and recommended by the WHO, it is recommended to have a confirmatory test for HIV. So although these tests are fantastic and they're 99% sensitive and 99% specific, they're still not 100%. And to really make a firm diagnosis of HIV, it's recommended to do a confirmatory test. And what does that look like? So the WHO does recommend that national labs, that communities have access to national labs where they can send blood specimens that have a first positive HIV test that can be confirmed within an algorithm. In general, there should be a second separate and different HIV test that needs to be positive to confirm an HIV diagnosis. So the key point and things that could be done on a local community is working with the local government and the national government to really develop some guidelines for diagnosis of HIV.
Okay, bye.
And I'm happy to talk more about that. I hope that answers the question on the side here. The last point I just want to make, and then the last topic I just want to briefly talk about, and then I'm happy to take any questions, is just talking about treatments for HIV. And so I did see in some information that was sent to me a list of antiretroviral treatments. As many of you probably know, the cornerstone of treating HIV is multiple HIV drugs. We know that treating people with 1 or 2 HIV drugs is not enough, and that people develop resistance. So we know now from decades of study that the key number of medications, that active medications that people need to be on, are 3 antiretrovirals in order to actively suppress HIV over time, over years. So people should, in general, be on 3 antiretrovirals. In general, 2 of those should be what we call as NRTIs, nucleotide reverse transcriptase inhibitors. Those NRTIs I saw on the list that was available, that's actually the majority. So NRTIs include things like AZT, TDF, which is tenofovir, abacavir, ABC, emtricitabine, and lamivudine. So those NRTIs are generally what 2 out of the 3 ARVs should be on, and then the other ARV should be a different class. And according to what I saw currently on the drug list in Pakistan, the other 2 drugs that would be that 3rd drug are nevirapine and efavirenz. And those are NNRTIs, and they're very good drugs. I will point out, though, that those are recommended as a second-line treatment option now for people in some of these settings. So the other drug that I see that you have is Ataxanavir, which is a protease inhibitor, and that can also be that 3rd drug in combination with 2 NRTIs. I will make the point that in general, the WHO is now recommending first-line treatments as a class of drugs that I don't see on the list quite yet, but that includes integrase inhibitors. And the integrase inhibitor class are now first-line recommended in the United States. The WHO is now recommending them as first-line, and the reason for it is just frankly because they're fantastic. They have minimal side effects, they're potent, they work, there's low levels of resistance. So in thinking about working with the government and drug supplies, thinking about including or getting access to integrase inhibitors really would be ideal in general. The other thing to get access to, just in terms of diagnosis and monitoring people, would be access to viral loads and CD4 cell counts. Those 2 labs are really the cornerstone of monitoring HIV. CD4 count is a marker of the immune system. People's CD4 counts in people without HIV is generally above 500. When CD4 counts get below 200, which on average takes about 6 to 8 years, that's when people are termed to be immunocompromised, less than 200, when they're termed to have AIDS. That's when they're at risk of getting sick from other diseases. And that's when you also want to think about prophylaxis with antibiotics. I see that you have Bactrim on here, some sulfa drugs. That's when you want to think about starting some antibiotics to prevent some of these opportunistic infections. It's also critical to have access to viral loads. Viral loads are what tell you if the medications are working. I would say that that viral loads are perhaps one of the key lab things that you need access to. That is how you monitor if the medications are working, as well as when they fail. And again, the goal of treatment is really having a suppressed viral load. And again, on an individual patient level, that will protect people and keep them healthy. And on a public health level, it will prevent people from transmitting HIV to others. And finally, on a final note, again, I know that there's still a lot of investigations and trying to understand what's happening in Pakistan, but I did want to point out that it would be important to also test for some other diseases as well, some other infections. So a lot of times HIV is transmitted with other blood-borne diseases. The ones that really come to mind are hepatitis B virus and hepatitis C virus. Both of those can cause severe liver disease and chronic liver disease. And certainly if there's any concern about this being transmitted through contaminated blood products, testing for hepatitis B and C would be recommended to be caught early. So I think I'll stop there. I'm happy to answer any questions or that may have come up.
Yes, Suzanne. Actually, we had some situation here in state of Rhode Island where we had some outbreaks of HIV disease in college students, and our guest speaker was very involved in those initiatives. So I am just asking Phil if you can just outline what we did as a whole team and with Department of Health to control those outbreaks.
So I think the first step, which sounds like what's being done currently in Pakistan, is to understand where are the groups being affected. So here in Rhode Island and in the United States, the epidemic really centers around gay and bisexual men. And so that was the first key in our college investigation, was understanding what are the risk factors, what are the groups, how are they meeting people, etc. And then we did a lot of outreach in terms of testing the groups at risk. And that's what I would recommend here as well. So in terms of understanding how how paramount, I think, is understanding how HIV may have been transmitted, what were the sources, and then once you have a firmer understanding of how it was transmitted, is really doing education, awareness campaigns, making sure that people have access to testing, and importantly, meeting people where they're at and engaging them in the community to really get them tested. There's probably going to be a lot of stigma, of course, and a lot of concern about HIV. It sounds like there already is. So really, education and awareness about HIV in general are key to addressing a lot of this.
First of my question is that once you have viral infection and you continue with viral load testing in medicine, and you are negative now or undetectable by viral load testing, do you still recommend, or is the other recommendation to continue with maintenance type of medicine for maintaining? Yeah.
So great question, and so I should clarify a couple points. So when someone is on medications and undetectable, it does not mean that they're cured. So the medications suppress the virus indefinitely as long as you're on the medications. Unfortunately, at this time, there's no way to cure HIV, and if you stop medications, then the virus starts to come out again from long-lived cells that it's hidden in, and it starts to infect other cells again, and the whole process starts, and people's viral loads become detectable again to the tens of thousands, if not higher. So it is important when someone is on treatment that, unfortunately, at this time, is that they need to stay on treatment for the rest of their life to suppress HIV. That being said, we now have we've followed people for decades and decades, and these medications in general are very safe and effective, and people do well. But that's a great point, is that one thing to keep in mind, certainly as you talk to people, is that we can't cure HIV at this time, and that they do have to take these medications, unfortunately, lifelong. It's recommended in terms of monitoring that people generally follow up every 3 to 6 months, at which point a viral load test is checked to make sure that they're still suppressed. It's also recommended in general that blood tests for kidney and liver are also monitored over time to make sure that the medications aren't affecting either one of those organs, kidney or liver.
With that said, I want to just have a comment, and any comments from the speaker also is, there are two different type of testing, basically. One for blood supplies, which is a very important part in spread, or at least we think might be the reason for in Pakistan. And number two is patient infected individually via continuous use of the same needle or some other form of blood or liquid transmission. So the difference between viral load testing and antigen antibody testing is cost-wise, it's humongous. So for example, in our center, I can tell you at Albert Einstein, For blood testing, we rely on pooling of testing. What pooling of testing means that whatever the source of blood supplies are, we pool them 4, 6, 8 sample at a time, and majority of them are negative, so we don't have to do anything. But if it's a positive, we go back and check those 6 sample, 4 sample, or 8 samples and see which one of that is a positive, and we eliminate that for further blood supply. That is for the blood supplies. But for the difference between antigen antibody versus viral load testing in patient is this, that the cost of antigen-based testing is about $4 to $5 in US currency, for example, and for viral load testing, it's about $50 to $55 per test. So again, for if you feel in Pakistan, if there is a concern that someone might be infected, the good idea is to, and both testings are very, very good, means they are very reliable, both of testing. And viral load testing actually is recommended for people who we know they are infected and or on medication. So continue monitoring that medication, viral load testing, to make sure they are not deteriorating, or there is a monitoring of other parameters also in addition to viral load testing. So with that said, we still have to, what I know is this, that CDC and WHO are recently involved in investigating the source or root cause analysis for this recent epidemic, and they have started their working. And I'm sure there are many people in Pakistan, Dr. Sumra and others, who might be participating in that type of survey or investigative part. So, as suggested, that then we can address specific needs, what the reasons are for that sudden outbreak.
This is Dr. Turk from Kalamazoo. I have a question about the treatment part. That are there any long-term side effects of this HIV therapy? And once the virus is suppressed, since it's a carcinogenic virus, do we also decrease the risk of lymphoma and other cancers in these patients?
Yeah, it's a great question. So the medications, let me start with the older medications for HIV. As some of you may be aware, actually had some very terrible side effects. So people used to get fat redistribution, people used to get neuropathy, there's pancreatitis, etc. The newer generation of HIV medications are really quite incredibly safe, effective. There are some side effects that are known, and they tend to be medication specific. So for example, efavirenz, which is listed here, tends to cause some vivid dreams and potentially some neuropsychiatric effects in a small number of people. We do see that. The current medications, though, the one key point, though, is that a lot of the medications really tend to be incredibly safe and effective. There's also one of the newer medications which the WHO has recommended as first line, called dolutegravir. That's an integration inhibitor. There is some concern about pregnancy outcomes as well. However, I will say that for certainly the newer generation of HIV medications, and I provide treatment to hundreds of HIV positive people, really, really minimal side effects.
I am a pediatrician, Dr. Shanti Lal from Lakana.
Pleased to meet you.
Thank you very much. So my question is, I am pediatrician and we are mostly dealing the babies who are suffering from HIV. We are diagnosing them on antibodies titer. We do not do the viral loads. So once we start treatment, how to monitor these children? Because we do not have facility of the viral loads.
Yeah, it's a great question. So I will remind people too that antibody, if the mom has HIV, in newborns is that the HIV antibodies can be picked up in babies, in newborns. And there is not a 100% chance that a newborn will have HIV if born to a mother with HIV. I believe it's around 30%, but don't hold me to that exact number. So there's a 30% chance that the newborn being born to a mom may have HIV, and that newborn, unfortunately, even if they don't have HIV, may still have antibodies to HIV because of the mom. So it is really standard, unfortunately, to get viral load testing in the newborns because there's no other way to test for HIV. The other thing that you could do is you could wait for a period of months to recheck. And again, I'd have to look up the exact time frame, but you could recheck HIV antibodies over time to ensure that they're still positive. But I'm not sure that I would start treating a baby for HIV, a newborn at least, just because they were antibody positive, unfortunately, because it means that they could have just gotten it from the mom.
Recently, outbreak occurs. We usually receive the baby from 2 years to 5 years of age, where the mother and father both are negative. They have acquired infection through syringing or contaminated needles.
Yeah.
And we are diagnosing on antibody titers only.
Yeah, so that's reasonable. So they should be, in that case, so a couple things. I would make sure that that HIV test is confirmed by a separate test. Sometimes, occasionally, we've seen it even here, occasionally there's a batch of HIV tests that are just bad. So I would definitely make sure that these are confirmed. But in that situation, as you're mentioning, it likely represents a positive test. And so really, in order to accurately get people on treatment and to follow them and to make sure the medications are working, viral load testing is needed. So I think that that's probably a pretty big gap.
So the follow-up question I have, Dr. Chan, is, say for example, if a newborn is positive, as we do not have viral load testing available, if the newborn is tested positive with antigen testing, does this antigen antibody, and if it's not infected, if he's not infected, do the antigen antibody disappear after a certain time? And if you repeat it after a few months, will it be negative, or it will stay with how long it will stay with the newborns?
So if the baby or child is truly HIV positive, they should stay antibody antigen positive for life. And that's what's going to distinguish a true positive from perhaps maternal transfer of antibodies, etc. So if someone has HIV, the antibodies will be positive now, 6 months, 10 years, they're always going to be positive. And that is one of the ways to tell for sure that someone has HIV.
So in cases where if it's transmitted from mother and baby shows positive antigen.
So if the baby has positive antigen, that may be a sign that they're truly HIV positive. I would have to double check that. Don't hold me to that for sure. But if they're antibody positive and antigen positive, I mean, the antigen is a sign, right, of ongoing viral replication. So if they do have that antigen, the baby, then that is probably a sign that they'll be positive. However, I don't know if that has been proven yet. So please don't hold me to that.
This is Dr. Turk from Kalamazoo, Michigan. I have a similar question, I think, to clarify, because it looks like there's a little confusion here. Correct me if I'm wrong, that if you have baby is antigen positive, means they are infected. So they are HIV positive and they will remain HIV positive and will require long-term treatment. Those who have antigen negative and antibody positive, that means they are not, we are not sure whether they are infected. Most likely they are not infected. They are just carrying the antibody which is transmitted from the mom. Would that antibody eventually disappear if they are not infected? That's my question.
Yes, it should. Yes, absolutely. My one point about the antigen testing, though, I am not personally, I don't view the antigen test as a very good test. It sort of supplements and complements the antibody test, but I would be nervous relying on the antigen test as a sole way to diagnose HIV. So I don't think that the studies have been done, and I've been nervous about antigen testing. We definitely see a fair number of false positives and false negatives due to the antigen testing alone. So I would be very, very, very cautious in relying on that antigen test as a way to solely diagnose HIV. But in terms of your other question, you're absolutely right. If a baby, a newborn, has positive antibody, but they're negative, they're truly negative, then that antibody test will wane and disappear over time if they're negative. If they're positive, then they will stay positive for life. Antibody.
Dr. Chen, Dr. Sumro here. I would like to give a chance to the Dr. Sikandar Memon, who is a program manager and in charge of the HIV program currently running into the SIN. Dr. Sikandar, go ahead if you have any question for Dr. Chen.
Thank you all people who are sitting and arranged this valuable conference. I am also grateful to Dr. Aziz, who is also keen to give education to all the people, doctors, clinicians who are treating such patients in Pakistan. I am Dr. Sikandar, Provincial Program Manager, Sindh AIDS Control Program, and I am dealing the case administratively, though I am not a clinician, but sitting with the clinicians. Now, I am telling you the protocol which we are following regarding the HIV positive cases. We have been told by the WHO protocol that a patient, a person who is coming on the health facility for screening purpose, he should be screened through WHO approved rapid kit. If he is positive on first kit, then immediately go for the second and third kit. If he is positive on 3 kits, rapid kits, then we start a treatment of that case. We have also facility of CD4, but nowadays we are not bound to do CD4, although we are doing, but the WHO protocol says, as per my knowledge, that we have to start the course of the HIV. So we are treating patients of HIV on 3 rapid test positive. So if there is anything wrong, I may kindly be guided. Number two, viral load is totally free of cost of all patients. We are doing 6 monthly of everyone, but those who are getting start treatment from first day, they are being tested for viral load after 3 months. And if viral load is decreased, then we test them for viral load after every 6 months. So it is free of cost. It is being done by the Aga Khan Hospital, and the Aga Khan Hospital is being paid by National AIDS Control Program through Global Fund. So we have facility of CD4 and viral load as well, and we are treating patients on 3 rapid test positive. If we are doing something against the protocol, I may kindly be guided. Thank you.
So that's fantastic. You're actually doing everything correctly, and it sounds like the WHO has provided guidance. The 3 tests, as long as there are 3 separate HIV tests, 3 separate brands of HIV tests, then you're doing absolutely everything 100% correct. And that's because occasionally people will react. People without HIV will occasionally react positive to a test because of because of the antigens that the test uses, if that makes sense. So when you're doing 3 separate tests, and if people are really positive over 3 separate tests, that is a pretty clear indication that they're HIV positive. So that's fantastic. And as you mentioned, access to viral load and CD4 count and doing it every 6 months is what we do in the United States as well. So it sounds like you're doing everything spot on, have received appropriate guidance, and are doing things appropriately.
Dr. Sikandar, question to you is do you do this 3 tests? What is the time between the tests? Same day, other days, week after, 2 weeks after? If there's any time period between these tests?
So good question. So the timing of the 3 tests is to basically validate the test that was just done. So I would think about it as, if you think about the 3-test algorithm, you can do them right away on the same day. If the first test is negative, if one test is negative, then you stop there. And you should use the most sensitive test or whatever test is most available. But if that first test is negative, then you stop and you call them negative. If there's any concern that they were recently exposed, then you can repeat that same test in a period of time. 2 or 3 months would kind of be the recommended time to repeat it if you're worried that they were recently exposed during the window period. If that first test is positive, that's when you go on to do that second and third test on the same day, right at that exact moment, to confirm that this person is HIV. If all 3 tests are in agreement, then the person has HIV. If 2 out of 3 tests are positive, then it's still a pretty strong indication that that person has HIV. But the 2 out of 3 can sometimes be a little bit more confusing. But certainly if someone has HIV, has long-standing HIV, all 3 tests should be positive.
Dr. Chen, I would like to introduce Dr. Jamro. He is the chairman of the pediatric department in Benazir Bhutto Medical University. He may have a few questions. Dr. Jamro, go ahead, please.
We have facilities now available, what Dr. Sikandar has told. But mainly problem is that if child is coming below 1.5 years, then what should be the final test we should do?
Oh, I'm sorry, there's a little bit of static. Could you please repeat the question?
We have children below 1.5 years, 18 months. So we have these 3 tests available. Is this sufficient to test only on 3 these tests, or PCR is required really?
PCR should be required. I would have to look up, I don't know off the top of my head what the time frame is for young children under 18 months of when the antibody should clear. I would have to look that up again. But in general, in the newborn, recently born population, PCR testing is recommended.
Dr. Farooq, Dr. Farooq has worked on the HIV program since 1992. Dr. Farooq, do you have any question for Dr. Chen?
Dr. Chen, thank you very much. My question only on side of the pediatric side. Can you tell me some points about the care and support of patients and the BCC and the community-based rehabilitation? How we do here? Because a big stigma about the HIV/AIDS now in Larkana, even the sin. So how we maintain this, remove the stigma on BCC and the care and support and the community-based rehabilitation? Thank you.
So great question. Question on how to remove or address stigma in the community. And I have to tell you, it's something we're still struggling with in the United States. So I don't think there's an easy answer. However, I think in this situation, and frankly in all situations, education and awareness are really the key. I will say certainly that given that the infections and the outbreak is affecting people without risk factors, is it may be a little bit easier to address. And what I mean for that, right, is that historically the groups that have been thought about as being affected by HIV include injection drug users and gay and bisexual men, etc. What's happening in this situation is that people seems to be infected through routine contaminated blood products. And so I think messaging to the community that this is not their fault, this is nothing that they did, that it's not a result of their action is really paramount. And really stressing that these people didn't participate in any, that they weren't injecting drugs, obviously, or having sex, etc. That this is a result of contaminated routine medical procedures, I think should allay a lot of screening or a lot of stigma, and then just telling everyone that they should be tested regardless, even if they have no risk factors, and making it more routine and focusing on that component of it would be my thoughts on how to address at least some of the stigma.
Dr. Chen, Dr. Bikaram, he's a Vice Chancellor of Liaquat University of Medical Sciences in Hyderabad. He's online. Dr. Bikaram, go ahead if you have any questions.
First of all, I'm highly thankful for you people to organize such a wonderful, nice program for the awareness of doctors, and ultimately we have to aware the masses, we have to aware the community, and so I hope that this program will be on every Sunday for Pakistani people every Sunday at 9 p.m. and in the next Sunday we will have a big interactive session. We will organize it. Now many people, about 3,000 people, they are watching your program on FM. Yeah, and so very nice. And what we have to need, what we have to do. We have to make 3 strategy plan to fight with the HIV and AIDS. So number one, we have to identify the cases of HIV and AIDS, and we should treat them. This is number one. Number two, what we have to do, we have to educate the community and the large scale, so that we can prevent other people to have a to prevent themselves from HIV infection and AIDS HIV infection. So what we need to do, that in public sector and all community, we have to share your lectures. We would like to hear your lectures first by the doctors. Then we will communicate your message as a university to the every. We will try to communicate your message through as a university through our FM radio and the public by arranging the different workshops and these things. So definitely, if we will not do this, then this will go. But you know, hepatitis C, there was a big burden of hepatitis C in Pakistan. And the route of transmission is almost the same in hepatitis C and HIV. Although the amount, you see the quantity of the blood is lesser for the to transmit the HIV hepatitis C, while in HIV it's little bit higher. So you have listened the Larkana people that the mother, father both are HIV negative, even then child having the HIV infections. Many means there are some problem either this, at the management side and hospital side, and so this may be one of the case. And thank you very much for inviting me to talk on this forum and this discussion. In our laboratory, apart from Sindh government, although we are the university, we are under the Sindh government and HEC both, and we have got our own autonomy. So we have what we do in our university. Every patient is any patient who is coming over there for surgery or blood transfusion, anything, we are screening these people for the HIV. And we have got a highly sophisticated equipments for to have a PCR of HIV. If the government or anybody will provide us the kits, otherwise as a university, we can do on a no gain no loss basis, because that our diagnostic research lab has got 30 branches in Sindh, whole province of the Sindh. We can screen, we can help out the patients on their doorstep through our 30 labs. These all labs are almost 18 labs are state labs, and other labs are collecting points. So we can help out our community in this way, and we will definitely. The PCR kits are not for HIV. PCR kits are you see these are we cannot arrange by our own, but we cannot charge the patient of HIV. So I request on this forum, if anybody wants to do the research, they wants to proper to survey to help the people, then we have got two things. But first we will diagnose and we will screen the people. High risk, we will divide the patients in 3 groups: high risk group patients, and then non-HIV patients, and then third one is the kids, children born to the parents having HIV. So in these 3 groups, we will do the test accordingly. We will classify, categorize, and then our Department of Public Health and Community Medicine is under. So we can we should do you see, we should do the campaign of awareness among the population and the prevention of HIV, and you know, many people have got the misconception. One having the HIV, and that patient usually hides his disease because nobody is going to shake hand with those people. So we will try to clear the misconception of the patients regarding the HIV, but as I have already done as a focal person of hepatitis prevention and control program of the SIN in the past many years. So we will also try to clear the community for the misconception, and we will try to make a clear concept to the patient. Thank you very much.
Dr. Sikandar here. I have two questions from Dr. Chen and one request to Dr. Bekharam. Two questions and guidance. One is that we are doing 3 rapid kit tests, 2 at the site where we are screening the people, Ratodero, first and second. If we find 2 positive on 2 cases kits, then we refer the patient to the treatment center for third test, and we do third test on second day. Whether it is right or wrong, we should do third test on the same day, or we can give 1 day. Number 1. Number 2, if we are doing 3 rapid tests and we found 1 test negative, we don't start treatment of that patient. We say it as a window period, and we call the patient after 14 days on the same treatment center for retest on 3 rapid kits. And then if we found positive, then we start the treatment. These I want to see guidance whether we are doing correct or we should change our protocol. Number 3, Assalamu alaikum, Dr. Bekharam Sahab. I'm very happy you are here being a Vice Chancellor. I have seen that no Vice Chancellor except Shahid Benazir Bhutto Medical University, she is always there. And now you are also there. I would request you all that you people have established laboratories. As you said that you have 30 laboratories in across the province. I would request humbly that you make available the kits of WHO approved, and the charge only the fees from the patient, because people are charging 500 and 1000 rupees from each patient. The cost of kit is not more than 125 rupees or 150 rupees. You voluntary basis declare in the newspaper that test is available. Whosoever is interested to get himself tested, he should come on your laboratory and get him tested with a due cost, that is which is not more than 150 rupees.
Thank
Please
you.
help us in this.
Dr. Chen, go ahead. Dr. Chen has to leave. Go ahead, Dr. Chen, if you can address the questions by Dr.
Yeah, so good questions on the HIV testing. So to answer your first question, no, the third test can be performed whenever. It does not have to be performed on the same day. If a person truly has HIV, then that third test should be positive no matter when it's done. So it can be done on a different day, it can be done a same day, next day, a week later, should still be positive. In terms of recommending the 14 days for a follow-up test, that is the bare minimum time. I would say, I know that's what the WHO recommends, and I would say it's okay, but we generally, if I have a patient in front of me here in the US and we test someone and they're negative, and I'm concerned that they may be positive, but we may be in the window period, I'll generally tell them to come in 1 to 2 months. And so remember is that they should be positive, and that window period can extend as far as 2 or 3 months. So 14 days may not always catch it. And keep in mind as well that HIV is a disease of years. So if you don't diagnose it within a couple months, it's okay. Ideally you would, but even if you repeat that test a couple months later and it's now positive and it was first negative, then no harm has been done to the person and you can start them on treatment at that time. So I would consider the 14 days the absolute bare minimum time to retest someone. And I would say ideally it's probably more like a month or two to retest them.
I will say thank you, Dr. Chen, because I understand Dr. Chen has to leave. Dr. Jilani?
Thank you very much, Phil and Dr. Chan. I will talk to you in office. And say I'm just listening and I'm so happy. This was the sole purpose of these webinars, our effort to connect you, all of you with each other, to who can get help from each other, different universities, centers, and we will provide our best help, whatever we can do. So briefly touching on the next upcoming webinar, we are inviting our HIV Clinic Medical Director, Dr. Garland. He will be talking about our state-of-the-art HIV clinic and how we manage it. And then he will walk us through the first visits of mono HIV infection and co-infected patients with HIV, Hep C, and Hep B, and then the follow-up visits. So please, and after those webinars, the next two webinars will be solely about the treatment. Treatment in pregnant women, treatment for children, and treatment for co-infections. And we will bring our, all of our experts here. So Rizwan, are you done with your questions?
So yes, I'm done. But if people have any question, I'll be happy to comment. But one thing I wanted to add to your comment is that so this will be hopefully will be a series of seminars, and if there is a need for any topic which you like us to discover further or discuss further, we'd be happy to organize that topic also. So for example, we recently talking about psychological effect of AIDS in family and in patient, and hopefully we will develop we will have some psychiatrists like Dr. Aziz and others who might join us for talking about those issues.
So this is what we did last time, that all the providers, and when we say providers, it doesn't mean only doctors. We have doctors, nurses, midwives, and anyone who is providing any service to our patients in the hospitals. And we said empower your healthcare worker with the knowledge of HIV disease and encourage them to talk to their patients with respect and empathy. Teach healthcare workers that with the proper HIV treatment, this disease can very well be managed. With latest HIV treatments, patients can live longer and normal life. Empower the patient with knowledge of HIV disease and a few others. Then we also presented some patient-provider communications. During provider-patient communications, please keep yourself calm, keep patients and families calm, and tell them in simple words what HIV disease is. Treat patients with respect. Do not discriminate the patient based on the disease. Show empathy. Tell them you are here to help the patient and their families, and train providers and patients about the optimal treatment plan. Next, these are some myths which we discussed in our first webinar. Generally, please explain your provider and patient that HIV/AIDS cannot be spread through saliva, sweat, tears, casual contact such as sharing food utensils, towels, and bedding, swimming pools, using same telephone sets, toilet seats, biting insects, hugging any person who has the disease. Means if your child is HIV positive, do not stop hugging him. Or if your parents is HIV positive, do not stop hugging them. And shaking hand with any person who have disease. Some of these issues was briefly touched by Dr. Chan. So this is the list of HIV transmissions which we found so far. And we did say here that first one is doctor-induced procedures. Second, this includes any kind of healthcare providers in hospitals and private clinics. Second is heterosexual and MSM unsafe sex with any HIV positive patients. I think we should design the campaigns according to our culture and taboos. Things can be very different than campaigns in USA. Then shared needles by injection drug users, shared crack cocaine users snoring instruments, blood transfusion, contaminated blood used for transfusion, shared contaminated razors within a household, share contaminated shaving blades by barbers or beauty parlors, contaminated instruments by dentists, and here come the dentists and it is a big role there too. Contaminated instruments used by midwives, and contaminated instruments used for ear, nose piercing, circumcisions, and tattoos. So these are different transmission modes which we collected from different research studies from Pakistan. We have around 60 studies from different small HIV reports. If you want to add any new transmission mode which is not here so far, we can add them more and then we can create flyers from them. I think here this is what we have, and if you have any questions, discussions, please either write or talk. We are opening everyone. Okay, so this slide is a brief description of our next webinar, and you can see our guest speaker will cover all of these issues. If you want to hear anything else, please let us know. And the webinars after this one will be covering all the treatments, so you can prepare your questions and we will bring all those experts here.
Assalamu alaikum.
Sure.
I'm Dr. Sundari. I need these all material if can be available, so I may get it translated in Sindhi and distribute among the community through lady health workers. It is very much useful for me. I have ever seen, because we have also material, but that is for particular high risk population. Now this horizontal transmission of infection we have seen and observed, particularly in the children less than 5 years. So we want this kind of literature, or more than this, sophisticated and particular for children and mothers, parents who are infected in HIV. So this, if this may kindly be provided me, so I may get it translated and printed through donors or from government of Sindh, number one. And thank you all. You have done a lot, but we need this kind of lectures to the, although these all are clinicians who are involved in this lecture and listening and contributing in the district discussion, but we need particularly lady health workers to teach and trained, so they are in their community and going to households to teach the public that when you go to the doctors, don't use the syringes. If it is mandatory and essential, then you buy yourself, give the doctor to inject you, administer the drugs. So practically these lady health workers needs more trainings and education and literature to go into the community particularly. But doctors, we people are, and doctors are sitting in the offices and hospitals. Community is approaching doctors and barbers and everywhere. So community teachers are the lady health workers. So can anybody help us to train this lady health workers? We have 22,000 lady health worker force in Sindh. Every province, every district has more than 1,000 lady health worker. In Lorkana, I have seen very much good work of lady health workers. 938 lady health workers were trained by my program, and now they are going to their catchment areas. They have conducted more than 8,000 sessions. They have trained or provided information to more than 2 lakh people. So I hope that you will help me and also provide me this kind of slides. And if somebody is there to get it translated and printed and provide me, I will be thankful to him or her.
So this is Saifullah Jamru, right?
No, this is
Who was
Dr.
talking?
Sikandar Memon. He is in charge of the HIV program in Sindh.
Okay, so thank you very much. You really talked what we were looking for, and we are looking for the ideas. So we can definitely post all these slides, and maybe from CFAR website, our CFAR is helping, and they are thinking to create the website specific to this project on starting from Tuesday. But before that, you can send me an email, and I can forward you these slides. Webinar 1 and webinar 2. I'm not sure you were there in webinar 1, but we covered lots of social issues, and you can pick whatever you want to start, and also we can do a few webinars for lady health workers. And but I will say all these medical schools, they should step up. This is my personal opinion, please. So they should step up and train their case managers, social workers, and lady health workers for the field work. And we can work with these medical schools to prepare a small, like, training course. Medical, yeah, Miss. I will say all these medical schools, they should step up now and train their field workers.
Dr.
So
Jilani,
I would like to add, yes, I like to add that we have already talked about translating this material into Hindi, and we will work with Dr. Aziz to make it authentic and valuable for all the population. Number 2, lady healthcare worker is a great point, and we will discuss among ourselves and see how we can reach out to those lady healthcare worker for educating and prevention and caring of AIDS patients. We will definitely work on it.
Yes.
Dr. Jilani, next week, Jacobad Institute of Medical Sciences and Gumbert Institute of Medical Sciences, their clinical staff, the physician will be joining us. And I will assure Dr. Sikandar Memon, Dr. Jamro, Dr. Farooq, Dr. Bikaram, in all those institutes, we as a group from here will do our best to provide education, printed material, as much as we can as a volunteer group. We will be there for you and will support you.
Yes, Aziz, you mentioned volunteerism. I think that is very important. I want to show you all this screen where we have the disclaimers, and this is important. If you can see this screen, we say that all views expressed in these webinars are all of presenters only and do not represent views of any institution. Number 2, this is a volunteer project to reduce stigma and increase awareness about HIV disease in Pakistan. No one is hired and paid by any institution to do this specific project. Number 3 is our group does not affiliate itself with any political, ethnic, or religious denomination. So please keep this in mind. We are here to help you, and this is a volunteer work for all of us.
Anyone has any questions? Dr. Sikandar, Dr. Jamlo, Dr. Bikaram, or anyone right over there?
Dr. Sumro, this is Dr. Turk. I've got one suggestion to Dr. Sikandar, since he's in charge of this HIV program, and also Dr. Bikaram, that the goal is to reach to the common people in the villages, because they are the people who do not use any modern techniques like Facebook or even webinars and all these things. The best way to reach them is, number 1, the electronic media. I think they should start some kind of a campaign, some kind of a programs on electronic media to educate the people. And that's I think fastest way, because people do watch TV in the homes and everywhere, even in the small towns.
Dr. Turk, this project is specific to create awareness within healthcare providers, and we are saying that again and again. We are helping healthcare providers who are overwhelmed at this time, and patients are you are very right that patients have completely different needs. And I think many other NGOs and people on grounds are helping patients too. But our specific project right now is towards providers, but maybe in future we'll be able to open this up for the patients too, for the communities too.
I'm Dr. Sefla Jamro. You have talked very well on the counseling for the prevention, but recently we have started the clinic. So we have problems of the patients who are getting the medicines. Number one problem, we get vomiting, very common with the side effect of these drugs. Plus, they always ask how long treatment will go, because this is very important. They have to take that medicine for lifelong. So any counseling regarding this?
Yes, I think we always suggest pre-test counseling, post-test counseling, and we have to calm down the patient. They have to use this medication for the rest of their life. This is unfortunate, but this is what it is. Yeah, it gradually gets better, but these side effects, but this is will leave up to the healthcare providers or up to the doctors to change the regimen to take care of that. And our after next Sunday, we'll have 2 webinars on treatment. So you can prepare your questions, you can discuss with our experts then.
This is Irfan Suleiman from Washington, D.C. Just want to say thank you, everyone, especially Dr. Kilani, Dr. Rizwan Naim, Dr. Aziz Somro, to do this wonderful job, and it's really neat at this time to help our community in Pakistan. And thank you.
We'll just close the session. We will close the sessions for today, and we will resume next Sunday, 9 p.m. Pakistan time, and that will be the seminar on the treatment. Now, I would like to thank you, all of you.
No, Somru, next session will be about HIV clinic.
Okay.
Where is that? This is the next session, which will talk specifically about the working of HIV clinic within a larger hospital, and all about patient visits, how we do here, and how the HIV clinic works with all other institutions in our state. And Dr. Garland, who is covering this, he is a HIV Hep C person, so I will request him to touch co-infection with Hep C a little bit too. Okay, thank you very much.
Thank you very much, all of you.
Can I comment? Can I comment few words?
Sure.
Hello.
Yes, sure. We are listening.
Go ahead, Dr. Bikaram.
Yeah, I want to, for screening purpose, in my mind, we have categorized the patient. Number one, the route of transmission is same of hepatitis C, B, and HIV. So we have already network of the hepatitis C clinics as around throughout whole scene. So we should train those focal person doctors. First of all, we will make a workshop for the training of those doctors and for the screening. And then at the management side, I suggest Dr. Sikandar to the focal person of for the HIV and AIDS program. Then he should go through that network. Number one. Number two, TB sanatorium. Any patient having the TB tuberculosis, register anywhere. We should screen those people, and any family member having the HIV, we should screen whole family of that. In this way, we can go quickly to those patients who are having the HIV. So this is my suggestion. But otherwise, in my laboratories, all laboratories, the HIV kits are available. So anybody will come over there. We will not charge extra money from those patients. We will only charge the money of the kits. We have got 30 labs, and from here I'm announcing another thing I want to share with the Dr. Sikandar and you all people. This whole discussion is available on the LUMS FM 96.6. This will be available rest of the time, and people will listen it. Anybody want to listen this whole discussion on live, then it is available on our Facebook. LUMS FM 96.6. Thank you very much.
Good. Thank you very much.
Well, thank you very much. We will resume next week.
And thank you very much, Dr. Jilani, Dr. Iftikhar, and Dr. Rizwan for helping us.
Great. Thank you. And Khuda Hafiz, everyone.